Just waiting for that number to stop counting.
I think you're okay. They can join while you introduce.
Okay. Can you hear me okay?
Yep.
Good morning, everyone, and thank you for joining us for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive CME credit for attending today, the login information can be found in the chat feature at the bottom of your screen. If you have any issues with the webinar or the CME login, please send Julie Hawkins an email or drop a note in the chat feature. This morning, we are excited to welcome Corrine Faivre-Finn. Dr. Faivre-Finn is a professor of thoracic radiation oncology in the Division of Molecular and Cancer Sciences at the University of Manchester, and she's an honorary consultant clinical oncologist at the Christie Foundation Trust. She has a special interest in lung cancer. She trained in Paris up until 1998 and then accepted a consultant post at the Christie in 2001. Her interests lie in the development of advanced radiotherapy techniques and combined modality treatments for stage 3 non-small cell lung cancer and also small cell lung cancer. And as you know, she has some major publications in this area, including Convert, which I think she'll be touching on today. Her presentation is the modern management of small cell lung cancer. Welcome, Corrine, and thank you for joining us today.
I thank you very much, Jeff, for the introduction. So it's my great pleasure to talk to you today about the modern management of small cell lung cancer, which is one of my great area of interest. So I'd like to start with a few photos, if it wants to work. Oh, there you go. Of my good friend, Wally Curran, who I think has just joined this webinar. We've had a lot of fun over the years at various conferences, and you can recognize on these slides a lot of leaders in the field of lung cancer. And I was just telling Jeff before we started that he must keep away from a dance floor because for some reason he's not on these photographs. So Wally, we do miss you a lot, and I hope you come back to, you do attend these conferences in the future. So I thought I'd start by telling you a little bit about Manchester. So it's in the northwest of England, and I work at the Christie Hospital. It was founded in 1892, and it had this very unfortunate name of Cancer Pavilion and Homes of the Incurables. Well, thankfully nowadays, hopefully we're curing a few people. And you can see that the Christie is known for a number of achievements in the field of oncology. I've highlighted in blue some of the achievements in the field of radiation oncology. So in 1992, we were the world's first center developing multi-leaf collimators. And in 2002, the world's first clinical use of image-guided radiotherapy on the LINAC. Manchester is also obviously very famous for football. So we have two very famous soccer teams, as you call it, Manchester United and Manchester City. So on the left-hand side, you can see what the Christie looked like back in the 19th century, and it's changed dramatically. We now have state-of-the-art facilities and centers. We are the largest center in terms of delivery of radiotherapy in Europe. We have 16 LINACs, including a research LINAC. The numbers actually have increased of clinical oncologists. There are now over 50 of us. And you can see that we're delivering a very large number of radiotherapy plans and fractions annually. What's great is that we are part of this Manchester Cancer Research Centre, and radiotherapy is obviously one aspect of the research that we do. We are working in very close collaboration with some fantastic colleagues. So at the bottom you have Richard Murray and Caroline Dive, who are world famous in the field of biomarkers, and we work with them very closely. And Rob Bristow has joined us from PMH now 3 years ago and is leading the research strategy. We have a number of themes within our radiotherapy department in terms of research. You can see here on the right-hand side, and a number of very renowned people: Tim Illich in the field of immunotherapy, radiotherapy combination, Catherine West in radiobiology, Peter Hoskin, who's a clinical trialist, and Marcel van Herk, who joined us from Amsterdam a few years ago. We were awarded a number of very large grants to develop radiotherapy research, and we were awarded the largest grant for Centre of Excellence in Radiotherapy in the UK. We also have the Lung Cancer Centre of Excellence in the UK and the Prostate Cancer Centre of Excellence. I'm not going to talk very much about this today, but something that we are very much developing at the moment is real-world evidence and real-world data. And we have a connected radiotherapy department where we can link our data sets all the way from the demographics, tumor characteristics, and the EPR, obviously the radiotherapy data, the systemic therapy data. We're now collecting electronic patient-reported outcomes in all of our patients, so it's not done in the context of research projects, it's in the routine setting. And our aim is to provide evidence in unselected patients who are typically excluded from clinical trials and develop decision support system. We also have distributed learning that we have developed with a number of other centres in the UK, but also elsewhere in the world. It was very exciting that almost 2 years ago now we opened the first proton centre in the UK, and we have a research room. So we are at the moment actually developing a study of proton versus photons in lung cancer, and we're seeking funding for it. We also have an MR-Linac at the Christie, and the Christie is actually leading the lung disease group of the MR-Linac. You can see the founding members of this MR-Linac consortium, but there are obviously others that have joined since. So just a few words about lung cancer in Manchester. So I see very few patients in my clinic who look like this, either young and fit or even old and fit. Most of my patients look like this. They are elderly and very frail generally. So you can see the numbers, very large numbers of patients diagnosed every year, over 2,000 new diagnoses of lung cancer per year. We have a very high incidence that is higher than the rest of the UK, and it's the first cause of mortality. We treat over 600 patients with curative intent radiotherapy per year, and we still have quite a large proportion of patients diagnosed with small cell lung cancer. And that is due to the fact that we still have quite high smoking rates in the Northwest. So now focusing on small cell lung cancer, as you will know, the incidence of small cell lung cancer has been declining over the years, but not so much in Manchester, as I said. This is a graph from the US. So, it's actually a very common cause of cancer death. It ranks 6 in the US. And the patients with small cell lung cancer, as you will probably know, have excellent responses to both chemotherapy and radiotherapy, nowadays also to immunotherapy. But unfortunately, few patients will be long-term survivors due to the risk of local relapse and also distant spread. So here's a typical case of a patient who is an ex-smoker who has COPD, performance status of 1. You can see the lung function. So this patient has a left upper lobe mass and involvement of station 4R, 4L, 5 and 7. The MR scan of the brain is clear. So there are clearly different ways of managing this patient. I'll come back to the question of whether PET-CT should be part of the diagnostic investigations. And you can see the treatment options. So the standard of care in someone who's PS1 is concurrent chemorads, but some people will still argue nowadays that if you have large volume disease, someone who's 76 with comorbidities, perhaps you should still give sequential, although that's not the preferred option. And you can see that there are many, many dose fractionations that are used around the world, either once daily, twice daily, conventionally fractionated, or hypofractionated. And this is a summary of the current evidence in patients with limited stage or stage 1 to 3 small cell lung cancer. So we know that adding radiotherapy to chemotherapy means better survival. We also know that we should be giving the radiotherapy early as opposed to late, and the best way of giving the radiotherapy early is concurrent as opposed to sequential. With regards to the best survival results published, they've been achieved with early twice daily concurrent chemoradiotherapy, and I'll come back to that. There is no role yet for immunotherapy in the routine setting in stage 1 to 3 small cell lung cancer. And then we know that prophylactic cranial irradiation improves survival. So the study that has established twice daily radiotherapy as a standard of care is a study published in 1999. Many of you will be familiar with it, I'm sure, comparing the same dose of radiotherapy, 45 gray, either given once a day or twice a day, starting with cycle 1 chemotherapy. And the chemotherapy was a standard cisplatin etoposide. And as you can see from this graph, there was a significant benefit in favor of twice daily radiotherapy, but at the expense of toxicity and partly esophagitis in more than a third of patients. So more than a third of patients in this study developed grade 3 or more esophagitis, meaning that they had to be hospitalized. So in terms of utilization of twice daily radiotherapy, so these are data from the US, but I couldn't find any sort of recent data actually on the use of PD radiotherapy. You can see that relatively low rates of twice daily radiotherapy are used in the US, certainly at the time of these surveys. So that led to the development of a CONVERT trial. And what I'm going to do in the next sort of 10-15 minutes is, in addition to presenting the main results of the CONVERT trial, I'm going to also show you some other analysis that we have done and published to show you how much you can do with one clinical trial data set. So the background is that obviously there were some issues worldwide regarding the implementation of twice daily radiotherapy due to concerns regarding toxicity, logistical issues of delivering twice daily radiotherapy in radiotherapy departments. And then there was also a criticism of the low dose used in the control arm of the Thoracic trial, which was 45 gray only. So as a result, there was generally a lack of consensus on what should be a standard radiotherapy regime in this setting. So the aim of the CONVERT trial were to investigate whether we could improve on the results of twice daily radiotherapy by increasing the total radiotherapy dose. We wanted to establish a standard regimen in this setting, provide toxicity and outcome data for concurrent chemoradiotherapy using modern radiotherapy techniques, because in the Thoracic study, it was mostly 2D radiotherapy that was used with elective nodal irradiation or partial elective nodal irradiation. And we also had, for the first time in a small cell phase 3 study, a radiotherapy quality assurance program. And then finally, and importantly, we wanted to understand the biology of this disease, which is clearly the holy grail. Standard inclusion criteria, as you can see, so patients had to be PS01, but if the patients with PS2 due to disease could be included at the discretion of the local principal investigator. So this is the study design. So the control arm is the best arm of the Thoracic study, 45 gray in 30 fractions, delivered twice a day. And in the experimental arm, a high dose of radiotherapy, 66 gray, delivered once a day. It was felt to be logistically difficult to start with cycle 1 chemotherapy, so we opted to start with cycle 2 chemotherapy. Both 3D conformal radiotherapy or IMRT were allowed, but no elective nodular radiation. We did not actually allow carboplatin up front in this study. It was allowed if patients developed toxicity, but the majority received cisplatin and etoposide. It could be 4 or 6 cycles. You can see the stratification factors there. So what is important to note in this study is that we had no upper age limit, because we knew from previous studies that data on the elderly was fairly limited. For the first time in a randomized controlled trial in small cell, the TNM stage was recorded as opposed to limited versus extensive. The PET staging was recorded again for the first time, and we had a quality assurance program. So I had the privilege to present the results of the CONVERT trial at the 2016 annual meeting, and the study was selected for Best of ASCO. You can see the patient characteristics, so generally a bit younger compared to certainly the median age in Manchester, so 62, 63 years. And that is generally the case in randomized trials. Patients tend to be a bit younger. You can see approximately 50-50 male-female, just slightly more male. Patients were vast majority PS01, vast majority ex or current smokers. Just over 50% had a PET for staging. Slightly less than 20% has stage 1 or 2, so vast majority stage 3 disease. You can see the gross tumor volume there. So these are the main results. So our hypothesis is that the survival at 2 years would be increased by 12% with once daily radiotherapy, so going from 44% to 56%. So as you can see from the graph, there was no significant difference between the two arms. We actually achieved our hypothesis of 56% 2-year survival, but not with the once daily arm. We achieved it with a twice daily radiotherapy treatment. And do note that the 5-year survival is 34%, so a third of the patients alive at 5 years, which is the best survival results reported in this group of patients. In terms of toxicity, there was no significant difference between once daily and twice daily radiotherapy. I mean, do remember that a third of the patients in the Thoracic study had grade 3 or more esophagitis. It was less than 20% with modern radiotherapy techniques. And also importantly, pneumonitis, severe pneumonitis rate of grade 3 or more were very low in the study. Also reassuringly, very low rates of late toxicity, such as esophageal strictures and fistula, less than 1% grade 3 or more. Pulmonary fibrosis, again, low, no severe myelitis, so all very reassuring. So CONVERT is a practice-defining trials. The radiation-related toxicities were lower than expected, likely due to the use of modern radiotherapy techniques. Survival in both arms was higher than previously reported. But once daily radiotherapy did not result in a superior survival or worse toxicity than twice daily radiotherapy. So the conclusion is that twice daily radiotherapy at a dose of 45 gray should continue to be regarded as standard of care, because CONVERT was not set up as an equivalence trial. However, I think it's fair to say that the once daily regime of 66 gray in 33 fractions can be considered as an alternative regime if twice daily radiotherapy cannot be delivered. So Tawfiq Yawinkoko did the discussion for the CONVERT trial ASCO 2016, and he presented this very nice graph that compared the survival over the years of various trials, and you can see here the result in terms of median survival of the twice-daily radiotherapy arm of the CONVERT trial. So you can see survival increasing, and then this bar chart also shows you the progress made over the years, with 5-year survival of less than 10% in this limited stage setting with chemotherapy alone, going up over the years with concurrent treatment, twice daily radiotherapy, and then this is the best arm of the CONVERT study, 34% 5-year survival. So I've just heard from Jeff that this study will be reporting at ASCO this year. So the CLG-BRTOG study that compared the standard, the best arm of the Thoracic study to a higher dose, so 70 gray this time, once daily radiotherapy. It also had a so-called boost arm which closed actually early. So we are looking forward to seeing the results of this study very soon. So just coming back to CONVERT, sort of developing a clinical trial at CONVERT takes a lot of time. Those of you on the call who have been involved in clinical trials will know that. I actually took the CONVERT trial many years ago to the EORTC AACR ASCO Methods in Clinical Cancer Research Workshop, which is the equivalent of the VALE a workshop that you have in the US. We have the equivalent in Europe. There was actually 12 years from the initial idea to the publication. More than 500 patients recruited, 94 centers participated in 8 countries. So it's really important to learn as much as possible from a data set like this beyond the main analysis. So I always say that data is gold, and I'm going to show you what you can do beyond the main results. And what's important is to develop the next generation. So you have photos of some of the people who've contributed to this analysis, including medical oncologists, scientists, physicists, radiographers, radiologists, statisticians, radiobiologists. And we want to really help these young people developing their career, which I will discuss with you after this session. So the first analysis was about the quality assurance. So you can see here that we had, we used the RTQA Global Harmonization Group definition of deviation from protocol. And to cut a long story short, we showed that the high recruiting centers are most likely to comply with a trial protocol. Overall survival was affected by the number and type of protocol deviations, and that highlights the importance of a robust trial quality assurance program in prospective radiotherapy trials. Then Mariana Christodoulou looked at the data in the elderly versus the younger patients. And what she demonstrated is that more elderly patients did not receive treatment as per protocol. The radiotherapy compliance was worse in the elderly. You can see the toxicity, so there's more hematological toxicity in the elderly, but no difference in pneumonitis or esophagitis, and no statistically significant difference in survival between the elderly and younger patients. So we concluded that the concurrent chemoradiotherapy with modern radiotherapy techniques is safe and effective for fit elderly patients. And Mariana received at the World Lung 2016 meeting the Heine Hansen Lectureship Award for this work. Then my colleague Hamed Salem presented on the early stage group of patients. So for the first time in a randomized small cell study, we had 87 patients actually with stage 1 or stage 2, majority stage 2 disease. And as you well know, there's a big controversy as to whether these patients should be treated with chemorads versus surgery. And generally, when we discuss these patients in our multidisciplinary team meetings, One of the discussion is around the data available, and often the surgical colleagues will argue that the results in the surgical series are better than the chemoradiotherapy series, but we did not have any contemporary series. So what we've demonstrated here is that the patients with very early stage disease had an excellent 5-year survival of 50% compared to 28% in the locally advanced setting, and not surprisingly less esophagitis in the early group compared to the locally advanced group, no difference in pneumonitis. So really this data compares very favorably with any of the surgical data, and it really provides some data that can be provided by clinicians and relate to patients to aid clinical decisions. We are lacking randomized data, of course, in this setting, and I very much doubt there'll ever be a study comparing chemorads to surgery in this setting. Then we just had this paper accepted just about 2 weeks ago about G-CSF. So as you well know, the ASCO guidelines had recommended for many years against the use of granulocyte colony stimulating factors with thoracic radiotherapy on a basis that it causes hematological toxicity and possibly severe pneumonitis. But that was based on very old data, mostly using GM-CSF as opposed to G-CSF. So in CONVERT, we actually allowed the use of G-CSF, and as you can see, 37% of patients had at least 1 cycle of chemo with G-CSF. And what we showed is that there was indeed more sort of paper toxicity with thrombocytopenia and anemia. However, in terms of clinical toxicity and particularly pneumonitis, there was no difference, and no difference in survival between patients receiving G-CSF and no G-CSF. So if you want to see more details about this quite complex analysis, take a look at the paper published in Lung Cancer. And this was presented by colleague Fabio Gomez at the European Lung Cancer Conference. So there's no evidence that the use of G-CSF during chemorads is detrimental to patients' outcome with modern radiotherapy techniques. So if you want to maintain dose intensity, you can safely use it. And then another very controversial question, the use of PET-CT for staging and making a decision as to whether patients should have or not chemoradiotherapy. So I'm not arguing here that PET-CT is not useful for radiotherapy planning, because it is, in terms of distinguishing collapse from normal, from the tumor, or deciding on whether to include some of the lymph node stations. But in terms of deciding whether to give chemorads or not, what we did in this study is that we compared patients staged with PET-CT versus patients not staged with PET-CT, and just over 50% had staging with PET-CT. We showed that patients staged with PET-CT generally had smaller gross tumor volume, less likely to have elevated pretreatment LDH, and received more chemotherapy cycles. But the other baseline and treatment characteristics were the same. And as you can see, there's no difference in survival, surprisingly, between the patients staged with PET and patients not staged with PET, and no difference between once daily and twice daily radiotherapy. So really the conclusion, and again, if you want to know more about this analysis, take a look at the JTO paper, is that conventional imaging is sufficient to select patients for concurrent treatment. And again, I'm not saying that PET-CT is not useful for radiotherapy planning. Then now moving on to the sample collections, you can see what we collected in CONVERT. And we did an analysis on circulating tumor cells, which was published in Annals of Oncology in 2019. So we looked at different thresholds for circulating tumor cells, showing that the 15 cutoff at baseline is the optimal threshold. And we showed that the CTC count is highly prognostic for survival, independently from other clinical factors, known prognostic factors, including the PET staging as well. 15 circulating tumor cells cutoff predicted less than 2-year survival in 100% of the patients and less than 1-year survival in 70% of the patients. And that provides a hypothesis to stratify patients prospectively for CTC count in future clinical trials. We have more analysis on the translational research that's still ongoing with CONVERT. So then we wanted to know whether CONVERT had an impact on practice. And this survey was performed in 2018, so things may have changed since, but actually we demonstrated that in Europe, the use of twice-daily radiotherapy went up from 32% to 42% after publication of the CONVERT trial. The main reason for not implementing twice-daily radiotherapy were logistical issues, inconvenience for patients, and the absence of a statistical survival difference between the two arms of CONVERT. So now, in terms of guidelines, what do the guidelines say? So in the last well, actually the last year, quite a number of guidelines have been published. So the ESTRO-ACROP guidelines, the ASTRO guidelines, and the ESMO guidelines will actually be published very soon. And they all recommend that twice-daily radiotherapy should be considered the standard of care in patients with good performance status. So, lessons learned. I think for me, the lessons I've learned running this trial is that you have to be very, very persistent, be collaborative, you'll get a lot more out of it, engage with young and enthusiastic people, and most importantly, have fun. So this was our ladies' night out. You will recognize some of these people, colleagues from the US, so Elizabeth Gore, Spring Kong, Maria Vernes-Basic, and my friend from London, Fiona MacDonald. So we just met for a nice drink and a dance in Chicago after I presented the CONVERT trial, which was a very nice feeling. So what is next? So one of the questions is whether the dose of twice-daily radiotherapy should be escalated, and there was a presentation on that at ASCO, but the manuscript is not out yet. So there was in a phase 2 study, a survival benefit for 60 gray delivered twice a day, but we're still to see the publication. The question as to whether we should be delivering more hypofractionated radiotherapy in this setting, but it's generally something that most of us don't like to do in the concurrent setting. The question of stratification of patients based on circulating tumor cells or circulating tumor DNA. And then obviously nowadays, one of the key questions is the addition of systemic therapy and particularly immunotherapy to the standard chemoradiotherapy regime. So I'll come back to that in a minute. This slide summarizes some of the key studies in stage 4 small cell lung cancer with immunotherapy, so Empower 133 and the Caspian studies, both showing a survival advantage if you add immunotherapy to the standard chemotherapy treatment of carboplatin and etoposide or cisplatin etoposide. I would like to highlight that we don't know very much about the addition of radiotherapy in this setting, and I will touch on that at the end of my talk. So in the limited stage setting, the question is whether we should be adding immunotherapy in the consolidation setting. And this study is the Stimuli study. It's an ETOP IFCT European study that looked at the addition of consolidation nivolumab, ipilimumab versus observation after concurrent chemoradiotherapy. And you can see the radiotherapy regimes that were permitted in this study. So the study was presented at the ESMO meeting this year, and I was asked to do the discussion for this study. So what was apparent is that the toxicity of the combination arm with nivolumab, ipilimumab consolidation was much higher compared to the observation arm with regards to a grade 3/5 toxicity, which is not surprising. But also what is quite concerning is the high rate of pneumonitis, 9% of grade 3 or more, which is much higher compared to what we reported in CONVERT, less than 3%, and the Pacific study was less than 4%. The primary endpoint was progression-free survival, and you can see there's no statistical difference between the two groups. And then again, no statistical difference in terms of overall survival between the two groups. But it's, you know, the 2-year survival is very promising, but you have to keep in mind that these are selected patients, PS01, who had responded to chemoradiotherapy. So if we compare CONVERT and stimuli, there are less patients staged with PET-CT in the stimuli study, and you can see the differences in terms of radiotherapy regimes. So the dose of once-daily radiotherapy was lower in stimuli. And then obviously you've got Kirsten Higgins in your institution, who is leading on the Energy LU005 study, a very important study that I understand from Kirsten is doing very well in terms of recruitment, looking at the addition of atezolizumab with both the concurrent chemoradiotherapy and also in the consolidation settings. So I hope this study recruits quickly and reports soon, because you know, that is the next important step, I think, in terms of improving the survival in this setting. Now, I've got a few more minutes. I would like to leave a bit of time for questions at the end, but there are loads of controversies also in the stage 4 or extensive stage setting with regards to PCI and thoracic radiotherapy. So starting with PCI, so we know from the studies done in the limited stage setting that PCI improves survival with a 5% benefit at 3 years. Now, in the extensive stage setting, this study was published in 2007 in patients who had responded to chemotherapy. Then they were randomized between PCI and no PCI. Please note that patients had to be less than 75 years of age. Primary endpoint was 1-year survival, and there was a very significant difference between the two arms. So 27% surviving at 1 year with PCI versus 13% without PCI, and a very marked reduction in the risk of brain metastasis. So these patients were not staged up front with MR. Oh, sorry. So that led, certainly in Europe, to a change in standard of care. But then in 2017, the Japanese PCI study was published. So it was different to the EORTC study. Patients had an MR scan of the brain at baseline. They were randomized with PCI and no PCI, but the other big difference is that they were followed up with MR imaging every 3 months for 2 years, which wasn't the case in the EORTC study. So there was no significant difference in survival between the two groups. The median survival was actually better in the observation arm compared to the PCI arm. There was a reduction in the 1-year cumulative incidence of brain metastasis with PCI. It's also important to note that the salvage brain radiotherapy was much higher in the observation arm, 83% versus 46% with PCI. I would also like to highlight there was limited quality of life and neurocognitive function data in this study. So if we compare the EORTC study and the Japanese trial, you can see here the differences. So one obviously favors PCI with regards to survival, the other one favors observation. And there are some differences. So I've already highlighted the fact that there was no baseline MRI in the EORTC trial. The patients in the Japanese trials were older, and there was a lot more salvage radiotherapy and also chemotherapy in the Japanese trial. It's also important to note that in Japan, they have 47 MRI units per million people, which is the largest ratio in the world, and it's not always necessarily feasible to perform these MRI scans in all settings. And another concern is the anxiety and the impact on quality of life that the repeat MRI scans will cause. So in terms of guidelines though, both the ASTRO and the ESMO guidelines still recommend PCI in this setting, particularly if an MRI scan cannot be done at staging or during follow-up. So in the US, you already have a study that is led by Chad Rustoven that is recruiting, comparing PCI to MR surveillance. And we are setting up in Europe a similar study called PRIMALUNG in collaboration with a number of European countries that will compare after baseline MRI of the brain, PCI to no PCI and MRI surveillance in both groups with cognitive function tests. So, both studies, the US study and the European study, will be very important in terms of establishing whether we should continue with PCI or not. I forgot to mention that this study will be recruiting both limited and extensive stage patients, so it's not just in the extensive stage setting. And then the final part of this talk with regards to radiotherapy for stage 4 small cell lung cancer is the role of thoracic radiotherapy, which is also quite controversial. So many of our patients present like this with these very bulky central tumors. There are abutting airways causing compression of blood vessels and so on. So it does make sense to consolidate the treatment with thoracic radiotherapy, but do we have evidence that it actually improves outcome? So this study, again, European study, followed on from the EORTC PCI trial. All patients who responded to chemo in addition to PCI were randomized to either thoracic radiotherapy, 30 gray in 10 fractions, versus no thoracic radiotherapy. Primary endpoint was overall survival. You can see the PCI regimen that were allowed. So what's important to say is that 95% of patients completed thoracic radiotherapy without interruption, and that the toxicity was very low. So fatigue was one of the most common toxicity, but you can see grade 3-4 toxicity in both arms was very, very low indeed. Now, the primary endpoint of this study was 12 months survival. And as you can see, there was no statistically significant difference. However, we had a predefined analysis at 24 months, and it was predefined, which showed a statistically significant difference in survival at 2 years. We also published this analysis based on 53% of the patients recruited in this study. So we looked in more detail at certain disease characteristics, and we showed that patients with less than 3 metastases without liver or bone metastasis actually benefit more from thoracic radiotherapy. So future studies could evaluate more intensive thoracic and extrathoracic radiotherapy in this group of patients. Again, we wanted to demonstrate whether this study had an impact on standard practice. And as you can see, there was a massive impact in Europe. So majority of centers did not deliver systematically thoracic radiotherapy before the study, 75%, and then that went down to less than 20% after the publication. And in terms of a dose and fractionation, the majority of centers were using the dose fractionation of 30 grain 10 fractions used in the CREST study. So these are the recommendations from the ASTRO guidelines recently published, and recommending for patients with extensive stage small cell lung cancer with a response to chemotherapy and residual tumor in the thorax that patients should have thoracic radiotherapy. One of the big unknown is what we should do in the era of immunotherapy, and in both studies I showed before, Empower 133 and Caspian, so PCI was permitted, but thoracic radiotherapy was not. So unfortunately we're lacking prospective, robust evidence on the role of these treatments in the era of immunotherapy. So it's something that is of great interest in terms of future studies. I'm coming to the end of this talk, so if you want to learn more about small cell lung cancer in general, we just had this paper published in Nature Reviews Disease Primers. There's a lot more, obviously, on radiotherapy, but also importantly on the genetics, the systemic treatment, the staging, etc. So please take a look at that. And I'd like to thank you for your attention, and I'll leave you with this quote, which I believe is the most important quality of a researcher. Thank you.
Thank you, Corrine. Well, we have a few questions. I'll let the questions accumulate. Let's see, while we wait on the questions, I wanted to let you know that next week we will have our own clinical trials office proving clinical updates and clinical research at Winship. To view all Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. Okay, we have 3 or 4 questions already. This one I think is from Jay Shelton, who's on our faculty. Since logistical issues are clearly important in the management of small cell, do you foresee any role in evaluating hypofractionation of small cell, limited stage small cell on a clinical trial?
Yes, thanks for the question. So actually, when we developed Convert, we had a lot of discussions in Europe about hypofractionated radiotherapy. And we had a number of colleagues who were very keen potentially to look at that. We initially had a protocol that had 3 arms, so similar to the CLGB study with a hypofractionated arm. But when we looked at the feasibility, number of patients required, it was decided that it wasn't going to be logistically feasible, and we dropped that arm. So there is some data, some old data from Canada on the 40 grain 15 fractions, which is still used there. And actually we have started using a little bit during the COVID pandemic in the UK, because obviously it reduces the number of fractions. But I think we're lacking data in the era of modern radiotherapy, really.
Okay. This one's from Dong Shin. For limited stage small cell, the addition of IO to the etoposide platinum regimen plus radiation versus etoposide platinum plus radiation during chemoradiation is an excellent ongoing study via Energy. Is there any role for maintenance IO after chemoradiation in small cell?
Well, so I showed you the results of the European Stimuli study. So it was randomized phase 2. There was no difference in either PFS or OS. But clearly it was a very toxic regime because it combined nivolumab, ipilimumab. So I think that was a problem. I mean, the majority of patients did not actually complete all cycles of maintenance treatment. So it may well be, and there are a number of ongoing studies looking at maintenance immunotherapy in this setting. So we are waiting the data, and it may well be that more tolerable regime will, will confer, will make an impact on survival.
Okay. This one is from Suresh Ramalingam. It says, Corrine, great to see you. The question is slightly off topic. Can you comment on the results of lung art in non-small cell and its implication on the role of post-op radiation for resected R0 non-small cell?
Yes, so thanks, Suresh. It's, so we're delighted to present the results at ESMO this year. And as I mentioned to Jeff earlier, the manuscript is in preparation. So there was no difference in terms of progression-free survival, which was a primary endpoint between port and no port in lung art. So the conclusion is that there is no role for post-op radiotherapy in patients who have R0 resections. It's not to say that in patients who have obviously R1 resections or patients who have extracapsular invasion, which were excluded, by the way, from lung art, so there may still be a role. What is really important from lung art is that it provides yet again some further evidence that of the impact of radiation on the heart, because it was a lot more cardiopulmonary deaths in the port arm compared to no port arm. So we are looking at the moment at the analysis of dose delivered to the heart and whether we can learn more from that.
Yeah, that's a great idea. I think that we need to understand that issue very well as we can. Okay, Dr. Ribeiro from the Atlanta VA hospital says that we give the first cycle of chemotherapy right away while the radiation is being planned and start the radiation with the second cycle. Do you have any concerns with this practice?
No, not at all. So as in Convert, that's what we did when we wrote the protocol and we talked to various colleagues in Europe and in Canada. We're basically told, forget about starting with cycle 1. It's not logistically feasible. There is also, there are 2 meta-analyses that look at early versus late radiotherapy with various definitions of what that means. But one of them looked at radiotherapy starting with either cycle 1, 2, or 3. So at the latest cycle 3 of chemotherapy as a definition of early, and that demonstrated a benefit in survival. So generally, in our practice, we tend to start with cycle 2 as per Convert trial. In some cases, so if patients have very bulky disease and we really want to have optimal shrinkage of that disease in order to reduce those organs at risk, we sometimes start with cycle 3, but that is in the minority of patients.
We have a question from one of our residents who you'll meet later. He asks, have you been able to dive into cardiac toxicity differences between the BID and daily fractionation regimens within Convert?
Well, no, because what we didn't do is to collect every single radiotherapy plan. So although we had a quality assurance program, because of the funding that was available at the time, we only looked at a proportion of the radiotherapy plans. We don't have all of them. So we collected some data on DVHs on the case report form, but it was sort of limited data. So the answer is no.
Okay. So you mentioned, I'm out of questions for the chat, for the Q&A. So while other people maybe enter questions, I'll make a couple of comments. Kristen's study, Energy LU007, is accruing well ahead of schedule, which is ironic, given, well, CTEP funded trials within the US are down 20% in accrual during COVID overall, and hers is accruing ahead of schedule. And given that its predecessor took over 10 years to accrue, it's, the CALGB study took over 10 years to meet its accrual. This one's accruing ahead of schedule. So I hope it's true that we will get an answer about IO, concurrent IO soon.
Yeah, great trial. So keep going. Looking forward to seeing the results.
Yeah. one of the things about being in person is you would have Kristen there, you know, and we could have a, you know, open dialogue about this, but it's virtual. So Energy LU007 just activated. It's for the patients with extensive stage small cell, and you can treat up to 5 centers. So it's 5 ISO centers, 5 locations. So it's randomized to chemo IO plus or minus local radiation therapy. And it just activated within the last 6 months. So we're getting that off the ground.
That's thoracic?
Thoracic plus any
Plus
site.
extra thoracic as well.
Yeah.
Also similar to Bethko's study.
Yeah, in parallel to that, except, you know, it's up to 5 locations as opposed to 3.
Okay, that's great.
Yeah. And the dose, the dose is pretty open in terms of what dose you can give, whether it's a single fraction to a brain met or to a bone met or 10 fractions of the chest. It's pretty open. Do you use hippocampal avoidant whole brain, since you're talking about small cell?
No, no. So yeah, I didn't touch on that, but the answer is no, not routinely. And there is a study from the Netherlands that has compared hippocampal sparing to no hippocampal sparing, showing no difference in cognitive function. They reported at ESTRO last year, and I think the paper's just come out.
Okay, we got Kristen Higgins saying, thank you for a wonderful talk, Corrine. Well, wish we could meet in person.
So, I know, I'm on that next plane.
And I won't skip the next evening out. You know, you got pictures of Wally on the dance floor, so I won't skip the next evening out. We get a chance. All right. Thank you, everyone, for joining today.
That's great. Thanks very much for listening. And so I'm joining the residents on a separate link.
Yeah, the resident session starts, I guess it's a separate link, right?
Yeah. Okay.
Okay.
That's great. Many thanks for having me. Great to see you all.